The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell with Leading Age Michigan, and I'd like to welcome you to our March 3rd Safe and Calm webinar this morning. This month, we know it's been a year now since the beginning of the pandemic in the U.S. And after months of advocacy and pressure on Michigan policymakers, they have finally relented and loosened some of the visitation requirements. We do know that a major factor in that decision is now that most residents in long-term care facilities have now been vaccinated. And although Dr. Caldoun yesterday in the governor's press conference, she continued to focus on the number of nursing home outbreaks, but we want to also note that those numbers continue to wind down pretty steadily, and we will see that when we look at this week's numbers. So on our agenda today, Dalton will provide for us an update on our Give Seniors a Say campaign. He'll also talk about the budget, a few other updates, and some new bills out there. We will follow up with a quick look at the numbers, and then we will move to the new visitation guidance and several other updates as well. So at this point, we will turn the presentation over to Dalton Herbal, our Director for Public Policy.
Good morning, everyone. So we'll start with our update for our Give Seniors a Say campaign. As some of you may know, last week we testified before the House Health Policy Committee and House Oversight Committee. I believe these were pretty key to yesterday's announcement regarding visitation. We had many family members speak and share their stories, and we also gave testimony. You can see Dave Game there from Wellspring Lutheran Services testifying on behalf of all members. And we just wanted to give everyone a big thank you. There were several members, not just Wellspring, involved with this, and several families involved in our testimony. So we really appreciate everything everyone has done for seniors in our state. I think yesterday's announcement was a testament to the fact that seniors' voices can be heard. So moving forward, this slide was actually changed just this morning because they passed the supplemental budget out of the House and Senate last night, fairly late in the evening. So, as I said, it was passed last night. And this is the supplemental budget bill that does include funding for the direct care worker wage pass-through program. And there has been some changes to that program, which you'll see on the oncoming slide. And the date has been set for when it now ends. It will apply retroactively, but not to get into too much detail now. It is also important to note that the following changes we're going to be talking about are not final. The governor has not signed this bill, and it was just passed last night, so we don't really we haven't had a chance to gauge her response because she probably hasn't seen it yet. So moving forward, we'll go ahead and talk about the direct care worker wage pass-through program and its extension. So as it stands today, the direct care worker hazard pay wage pass-through program will be extended till September 30th, 2021. And we advocated and made sure that there was language in that bill that would make the funds retroactively apply to March 1st, or essentially set the end date of the program to September 30th and not have a break in between where funding will lapse. In this program, they're increasing the wage enhancement from $2 an hour to $2.25 an hour. And they expand the pool of eligible employees who can receive this. They will now include employees who meet the criteria in licensed adult foster care homes, licensed homes for the aged. They include direct support employees in this, but they don't offer a definition for what that is. And we're working with the legislature to help them define what they mean by that, because they haven't set that in place yet. Then they also extend it to job coaches working in supported employment arrangements. They also include a $2 an hour increase for frontline workers employed in child caring institutions. It's also important to note that the Same criteria will be used for documentation, impact on average compensation, and the ability to decline the increase is still available to all employees. I did include a summary to the bill linked there, but that's where we're at with the program right now. It hasn't been signed by the governor, but there seems to be some agreement that this is going to be what it is, and we definitely have agreement regarding the retroactivity to March. So I've been getting a couple questions about the Provider Relief Fund and the reimbursement for lost revenues. As you know, the PRF funds came from the federal government. So some of this is going to be kind of a federal update. So if you've been on the Leading Age calls, you may know some of this already. PRF funds can be used through June 30th, 2021, and the final report is due July 31st. Currently, in the federal budget bill, there are no funds to extend the program. So essentially, we're seeing kind of the end of this program unless something happens and changes. The federal budget bill is currently in the Senate and already passed the House. From a state level perspective, in the governor's proposed budget, not for the supplemental, but for her budget for the year, she did include $37.5 million to help SNF providers in regards to their lost revenues due to low census. But the work is just beginning on her proposed budget. The supplemental bill is kind of absorbing a lot of the attention right now. As for where the Provider Relief Fund stands today, there's still about $30 to $45 billion left in that fund. And as an example, the entirety of the phase 3 distribution totaled about $24.5 billion. So there is funds remaining for a potential phase 4 distribution, but CMS has yet to comment and Leading Age hasn't heard anything regarding a phase 4. But there are still funds in the PRF fund, but going forward, the funds themselves are in question. And then lastly, I just wanted to cover a couple of bills that were introduced just so everyone kind of knows that they're out there. The medication aid bill that we discussed on previous webinars was reintroduced. It was previously vetoed by the governor, but it's been reintroduced. No action has been taken up on it. There's two bills that both are looking to curb what MDHHS can do and establish an epidemic orders. So House Bill 4317 would create a nursing home advisory commission within MDHHS that would be filled with various representation from throughout the disciplines, and then they would be responsible to provide a report to the governor by September 1st regarding the status of the epidemic orders and how they're affecting skilled nursing care. House Bill 4318 would actually set the specified risk levels for counties and regions in the state, and it would be based upon the coronavirus test positivity rates. This bill was introduced prior to the announcement yesterday, where she changed some visitation guidance that Deanna will be covering later. So it'll be interesting to see where these bills go. Both of these have been scheduled to come up in committee and did, but they did not leave committee yet. And then a bill that we discussed very briefly last year, or yeah, probably last year now. House Bill 4325 was reintroduced, and this would require AAAs to have criminal background checks and essential registry for criminal background checks for each employee that they employ.
All right, thank you very much for that, Dalton. Before we get into any questions, we did just want to let everyone know, and I will go ahead and pull up my screen here. If you go ahead and head over to leadingagemi.org, we are, I guess I should say, we have just opened registration this morning for a SNF Regulatory Day coming up April 14th. So if you go ahead and head over to our events calendar here, It should just, obviously, you scroll down to the date here, you'll see Wednesday, April 14th, we will have a SNF regulatory day from 9 to 3:30 p.m. So you can go here, check out the event page, find out a little bit more information, see who's speaking. We have some great speakers, Dykema, Laura, Rolf, and the Compliance Star so far. You can see the breakdown of the agenda, registration rates, and anything else that you may need. And you can go ahead and register for that now. Again, that will be April 14th. So we still have a little bit over a month until that date. So go ahead and register as soon as you can. Now let me go ahead and pull up these questions, Dalton. Okay. Has there been any discussion around submitting reimbursement requests for the direct care worker wages through 2/28/21 when it is $2 per hour, and a new form for 3/1/21 and beyond when the rate goes to $2.25 per hour? I would expect this would be requested by the state like they did when the program crossed from September 30th, 2020 to October 1, 2020.
I would expect something similar to that as well. But it is, as I said, it's important to note that this hasn't moved out of the legislature yet. So what some of these things mean and how the program's actually going to function is still up in the air. The department hasn't had a chance or a shot at this because it's not technically a law yet. So we just kind of have the outlines of the bill. We do know the bill says that they expect to keep the reporting process in place. And since that happened on the last crossover, I would anticipate that happening again. But we can't be sure because nothing's been defined and the department hasn't had a shot to set their guidelines around this yet either.
Okay. Regarding the direct care worker wage pass-through, this expansion allows the pay for all employees listed in the PowerPoint slide shown, or just CNAs, LPNs, and RNs who happen to work at those locations.
So the outside, two issues here. So if we take the direct care worker or direct care support employee out of the conversation for a second, it would be all those who are eligible in those other settings who meet the previously established criteria. So your nurses, your CNAs, etc. As for the direct support employee, the bill itself just says direct support employee and is not defined. We feel that this may extend the program to other people supporting people in those settings, but the legislative intent is not known because the bill hasn't been passed yet. So we'll figure that out and we'll get an announcement out once we get some definition for direct support employee. But regarding your question, any employee in those other licensed areas would have to meet the previously established criteria. So they would need to have some sort of a license.
Okay. Now that HFA is included in the wage pass-through, how do we learn more about all of this, and is there reimbursement for this? We have not followed this since it was SNF only until just now.
So I would anticipate there to be a very similar process for HFA and AFCs in terms of reporting. In fact, organizations who have both may be able to report on the same form. We don't know at this time. Am I missing another part of the question?
I can, now that HFA is included in the wage pass-through, how do we learn more about all of this, and is there reimbursement for this? We have not followed this since it was SNF only until just now.
Yeah, so once more information becomes available, we'll definitely be distributing this through our various listservs. We'll talk about it on this call. We'll send it out to the members via our traditional platforms of member update and newsletter. So just stay tuned for now. Once again, it's not law currently. So we're still kind of in a holding pattern to see how this will actually be implemented.
Okay. What do they mean by job coach?
I am not entirely sure myself. That's also not defined. I think you could stretch it to mean consultant, but I'm not sure. So we're still working on getting some definitions from the legislature. Yet again.
This is Deanna. I do believe that there are job coaches for persons with disabilities who are in employment settings. And I think that that's probably what they're referring to. But of course, you're right. We will have to see how they define some of these elements later.
Yep, we had someone else say many people with disabilities have job coaches to be successful in their work.
I think that is correct too, because in another conversation I had the other day with the Senate Appropriations Chair, he did say that he was looking to help those who help people with disabilities in this direct care worker package. But once again, we need the formal definition out there.
Okay. Should we start to pay the wage pass-through now for AFCs, or should we wait until this is final?
Well, it's kind of hard to know because I don't know the situation of every business or every organization. From my perspective, I would wait and do a lump sum until this is signed. There is some things in it that in this bill that are controversial. It's a very, very large bill package. And I would wait until the governor signs the bill, but that's up to you. If you want to go ahead and move forward with paying them, you're free to do so. I would just hold off until we get some confirmation. The department itself has been fairly lenient as to how you pay out these funds, whether it be every paycheck in a biweekly sense or monthly. They've even allowed lump sum payments to workers. So I know there are several members taking advantage of very different types of reimbursement for their employees. So that's what I would do, but it's up to you.
All right. So thank you for all of that. It looks like that was our last question, so we can go ahead and move forward.
Okay, thank you, Dalton. We were going to now take a quick look at our numbers, the actual Michigan situation update for this past week. So in the United States overall, numbers have trended downward for the past few weeks. You can see the shift in cases per 100,000 persons in Texas and California. So there's been a lot of improvement there. But there are more cases occurring in some of the other Western states. Michigan has had good numbers overall, but we've had a slight increase in caseload over the past week as well. So you can see there's a slight shift in Michigan in the past couple of weeks from the second level to the third in terms of daily cases per 100,000 persons. So when we look at the B117 variant, which at this point is the only variant in Michigan, we can now see that Michigan is second only to Florida in the overall number of cases. This was a bit of a surprise to us when we looked at it, but we also think it could be due, and we haven't checked this, but it could be due to the large number of testing that we have here. It could be a concern in the long run if our caseload doesn't continue to decrease, and the speed and the acceptance of vaccinations overall are going to play a role as the pandemic moves forward. So this is something that we're watching very closely. It could be an issue moving forward. Here's our standard graphic that's been updated with the 7-day rolling average for Michigan caseload as of Monday, the 1st. You can see our numbers continue to decline markedly following the holiday peaks, but it did take a short, brief upward turn this past week. Pretty much the same is true of the 7-day rolling average number of deaths. It has also declined with several peaks and valleys along the way. These deaths do continue to trend downward, but they're still, again, going up and down a bit, especially in the past week. We see just a slight tick up as of the 1st. So a really important piece of news is that we have no counties in the CMS red zone this week at all. And this may become more important in the future. That red zone impacts the frequency of testing, and it also impacts the frequency of visitation. So as we talk about the visitation guidance later, we do have to remember that CMS has rules about visitation as well. To date, MDHHS has had more stringent criteria that we continue to be concerned about. But when they loosened up their criteria, we do have to remember that CMS has some rules for nursing homes about that. So you can see that we have no red counties, and we have a large number of green counties now, which means that they are less than 5% positivity rate. Looking at the nursing home facility caseload in Michigan, although we saw a slight uptick in overall cases, you can see that we have continued a marked decline in cases over the past several weeks. And this was as of data reported 3/1/2020, and those are weekly caseloads. The same is pretty much true for homes for the aged. The data here looks a little screwy to me. It always has. So I'm not sure how accurate it was in the beginning with those large peaks here and there. But there's no question that the caseload has decreased markedly over the past couple of weeks as well. For AFCs, again, a slight decline, although it does seem to be plateauing, at least for now, a bit. With a bit less trending downward than the other facility types. Still, the numbers overall in long-term care facilities have decreased markedly. So when we look at the long-term care facility data overall, as published by the state, we can see that we've had very few new resident cases, 25 in SNFs. For the past week, a total of 44 across all three settings. That's really some of the lowest numbers we've seen in a very long time. This is a trend we're going to watch, but we also have to note that we have quite a few staff cases comparatively. Because the residents are now vaccinated, but staff have not been vaccinated to the same degree, we know that that could be something that impacts us over time. So we'll track that trend and see how the resident and staff ratios continue. Overall, we're nearing almost 44,000 long-term care related cases and almost 5,600 deaths. So we're going to move on now to our general updates, and we'll start with the topic of the week, which is, again, of course, visitation. So overall, the visitation order simply eliminates the county risk levels as the basis for determining the level of visitation that the department's going to allow. So we pulled out a few of the definitions from the order to highlight them, but they're really not different than before. The rule still covers nursing homes, homes for the aged, adult foster care, hospice facilities, substance use disorder facilities, and unlicensed assisted living. The communal dining and group activity rules listed in the guidance apply only to facilities that house more than 6 persons. End of life is still required to be determined by a qualified medical professional. So these definitions overall pretty much remained unchanged. There are more definitions, but they're pretty routine in the order. A little bit more definition of communal dining requirements, a few more details. It still references the CMS guidance, though. You still need to have residents at least 6 feet apart. They must wear masks, and facilities must provide access to hand hygiene while dining. Otherwise, it's required to be consistent with the CMS QSO 2039. The reporting requirements also have not changed. Facilities must inform employees and residents of new cases within 12 hours. And within 24 hours, they must inform families and representatives. If there's an outbreak, they have to post a notice. Ensure that prospective residents and employees are aware of the outbreak status. And of course, you still have to contact the local health department for any positive cases. Facilities still must notify employees of any significant changes in CDC recommendations. They must keep records and report the availability of PPE within the facility. Report all presumed cases. Independent living facilities, thankfully, still remain outside of the visitation guidance, but they still must report any positive cases. So the section labeled visitation, this is where the language really starts to change. And rather than saying that visits are prohibited with a certain number of exceptions, the guidance now says that facilities must support and accommodate residents receiving visitors. So that is a direct 180-degree turnaround. We have to note here that when we have applied strong pressure to the administration about these visitation issues, lately they've been pushing back with the concern that facilities are not even allowing the visitation to the point that they're able. We do know that that may well be true for some facilities, but we also know that overall these rules have conflicted with CMS for months, and many residents have suffered because of the way they've been written. So facilities shall facilitate visitation, including indoor and outdoor. And outdoor visitation may become important again as spring approaches. There are visitor testing protocols that are still required for all entities covered under the guidance, except for AFCs. Testing is only required for those who are licensed for 13 or more beds. So visitation, indoor and outdoor, can occur when, and this is not new, there are no new cases for 14 days. The local health department has not banned admissions for the facility, and the facilities subject to testing requirements ensure that all visitors 13 and older are tested. And that includes all visitation except for outdoor visits and obviously window visits, which are also generally outdoor visits. So this next section includes the long list of requirements that facilities must meet for visitation. Pretty much the lengthy list has not changed. Visitation must be by appointment only. You have to log arrivals and departures. Visitors have to provide their contact information and ensure that they notify the facility if they develop any symptoms within 14 days of their visit. You must limit the number of visits at any time to 2 or 1, that's possible. You have to require the testing as defined. You must exclude anyone who's unable or unwilling to wear a face mask. And if additional PPE is needed, such as perhaps for an ADL visit, the facility is required to provide it. And limit visitor entry to specific entrances and screen everyone on coming in. None of those requirements have changed. Also, these pretty much have not changed either. The facilities must post signage about the need for screening, the need for testing, and also post that anyone with COVID-related symptoms should not enter. Visitors in general have to maintain physical distancing. That there are exceptions to that for those providing ADL visits and end-of-life visits, but there continues to be a limitation of 15 minutes for that closer contact. We have talked to MDHHS over time that 15 minutes is not long enough to really assist with seating. And however, they are holding to that 15-minute rule, most likely because that's the limit for exposures defined by the CDC. However, these persons should be wearing full PPE, so we still struggle with that, and we will continue to talk to the state about that going forward. Facilities, as usual, must make hand washing availability, sanitizer readily available. And they also have to ensure the availability of staff to assist with transitioning residents during visitation. And this long list of requirements continues. You must make visitors aware of any PPE that's required beyond masks. No visitation during aerosol generating procedures or during specimen collection unless absolutely necessary. Facilities must restrict visitor movements when inside the facility, provide a location for visits when there are roommates. So there should be no visitation in shared rooms. An employee or volunteer trained in infection control must be available during any visits. They're not required to supervise as originally. We're not really sure what that person is expected to do, but they're supposed to be available at any time that there are visitors in the building. It doesn't have to be the infection control person, but it has to be someone who understands infection control principles. Facilities can still limit the number of visitors in the building at any time based on space and infection control. Visitors are reminded not to share food, and facilities are required to communicate regularly with with families and residents about any updates to the visitation protocols. So here is the last requirement in this section, and this has been perhaps the most painful area for us. And unfortunately, it's still there. The requirements continue to disallow any visits to persons who are in isolation or who are in observation for symptoms of COVID. And this is the section that we have fought hardest against. We've already communicated since this new guidance came out with Elizabeth Hertel, the new director of the Michigan Department of Health and Human Services, that this is tragically affecting residents and families. Technically, this means that a COVID positive resident cannot get last rites and certainly can't see their family before dying if at end of life, can't see their minister. So technically, this is a problem. However, we do always want to note that CMS does allow these visits. And we refer people to look at the QSO 2039 to look at the CMS requirements for nursing homes because that conflict still exists. Additionally, as Dalton noted earlier, one of our members, Dave Game, and with some support from some families, from some of our other member facilities, they provided testimony twice last week to legislative committees. And during one of those, there was a definite pushback from one specific legislator who seemed to be defending the administration's actions. They implied that visitation should have been allowed for persons who are newly admitted. And this has been one of the more troubling requirements over time and definitely has had an impact on our members' ability to admit residents, since they'll not be able to see their family for 14 days. The CMS April 2 memo from way back when, April, includes that provision, that visits should not be allowed for 14 days for new admissions wherever possible. But try as we might, it is clear to us that this line from the MDHHS guidance prohibits visits to anyone under observation for symptoms, and that would include persons within 14 days of admission. So that is the way it stands right now. However, we will continue to work with the department and advocate for more reasonable guidelines, because this is one of the pieces that we believe is most concerning to families and residents. Outdoor visitation, pretty much these rules have not changed. Remember that testing is not required here. Physical distancing and protection from the elements, those are things that are still in the guidance. Window visits are always allowed. Persons without access to an outside window that can be used for such visits, that has to be accommodated as well. So you have to figure out how to allow a window visits for persons who might have a second story or a third story room, or whose window is not near some place accessible by a visitor. A window visit by definition must include a sealed barrier so that the visitor is always sealed from the rest of the facility. Parents always allowed for minors. That hasn't changed. ADL visits are allowed even when there is an outbreak and regardless of any health department guidance. So this section really talks about those exceptions to the outbreak requirements. ADL visits are not covered under that restriction. Visits for hospice residents or persons in serious condition are also allowed regardless of outbreak status. And for these ADL and hospice end-of-life visits, any denial of those visits have to be in writing. And that writing must include the rationale for the denial, and copies have to be sent to the Ombudsman and MDHHS. Those rules are not new. Medical service providers are always allowed regardless of outbreak status, and students are always allowed regardless of outbreak status. If you are in outbreak status, though, you cannot allow non-medical service providers. But apparently they are allowed if only a ban on admission on visitation has come from the local health department. So that's one of the examples or the exceptions to the non-medical service rules. This has never felt like a likely scenario to us, but that is the language that they put in this, and it's not new. Non-medical services are allowed when it's determined that there would be a negative impact without them. It does continue to say that in the guidance, but pretty much visitation is allowed pretty much in all categories as long as there's no outbreak. So we don't understand basically the idea behind that anymore. The same rules apply to volunteers who are assisting with visitation. The testing rules have not changed. Testing, though, is not required for any visitors under 13. And last but not least, the rules take effect immediately. So here is the grid from the state. It's a summary of the requirements. So although no visits are allowed to anyone under observation, according to the narrative, the grid does not actually say that. And so we're going to continue to converse with the department on that issue, and also, of course, advocate for end-of-life visits for COVID-positive persons. So basically, the change here is that you don't have to look at the county risk level. The county risk levels are still noted on the website, and there are still level E counties out there. There are several, but that level E no longer precludes the general visitation. So the rules are the same. You just need to take out the county risk level in identifying what you can do in terms of visitation. So let's take a few questions, Blake.
Okay, thank you, Deanna. Before we get into any questions, I'm going to go ahead and move my screen over here again. We did just want to show you guys and remind you one more time that once you have signed in up here, you can go ahead and head over to your My Profile, and from there, if you want to update your photo, add a photo, you can go ahead and do that. You can go to the Manage Profile section. You can see if you have any invoices outstanding. You can go ahead and pay those if you'd like. You can edit your bio, say you've changed jobs, you've changed titles, you've changed organizations, anything like that. You can go in there and make sure that all of that is correct. Where our database is up to date, everything like that. Make sure that if you want to receive all of our training alerts, if you want to receive our newsletter, make sure that you have these as yes. That way you are receiving those. You can even go in after we've said For all of our programs, we always tell you to go to the professional development section to grab your certificate of attendance for anything you've attended. So you can see that in this content and features section here, professional development. And you can click on this certifications and programs, and that will bring up everything that you have done with us and any certifications that you have. So feel free to hop in there and check that out if you haven't been in there in a while, update anything, and just that's about it. So thank you very much for that. Now I just see questions pouring in right now. So we will just start here at the top. Does the testing order from October 28th, 2020 still remain in place in addition to the testing mentioned in the March 2nd, 21 order?
Yes, the testing requirements have not changed. I don't remember off the top of my head if it had said that visitors under age 13 didn't need to be tested before. That might be a new piece, but I can't be 100% sure of that without looking at the older guidance. But the testing requirements have not changed. And in fact, the department hopes that people will use point of care tests so that you have immediate testing reports available. But if that isn't possible, visitors must be tested within 72 hours and bring proof of that to the visit.
Okay. For communal dining, if we have small households, for example, a 6-room memory care area or a 10-room greenhouse homes, can residents sit closer than 6 feet apart and be considered part of the same household?
I would be reluctant to do that, but I think that it does look like the guidance doesn't apply to those small settings, but I would look at your overall risk and make a judgment based on the CDC recommendations. Perhaps if all of your residents have been vaccinated, you have low community transmission rates, you have no outbreaks anywhere near you, staff is all clear of any infectious process, I think that it might be something for you to do. It does say that it only applies to facilities with more than 6, but I think that you'd have to look at your individual circumstance and decide what's best.
Okay. The order says make accommodations for residents who share a room, as visits for those who share a room should not occur in the resident's room. So we take this to mean visits can be in private residents' rooms now, correct?
Yes. And I don't believe that that's new. I don't think that's a new guidance. I think that the concern has always been that residents should not be having visitors in the room if they're sharing a room. And so a dedicated area for that has been made by a lot of facilities. Yes, the only thing that you might want to consider is that how close their room is to the entrance and how much they have to travel. So it's possible that for your given facility, a dedicated room might be more appropriate for those in a private room, but visits to a private room are allowed.
Okay. Do you know how they define prohibit visits to those who are under observation for SS of COVID-19? Does this refer to those in new admission quarantine and also those who go out to dialysis that are in permanent quarantine?
We do believe that it applies to persons who are under observation for 14 days following admission. We believe that that's what it says as written. CMS, I think, although it hasn't been 100% clear, doesn't include that requirement in their latest visitation guidance, but they did include it in an earlier memo of April 2, 2020. We're working to clarify this with the state. The fact that they didn't remove that language leads us to believe that that is the intention, and from discussions way back when, it was always the epidemiologist's intention to make sure that they were protecting people from persons coming into the facility who are listed as COVID unknown. So we are continuing to advocate for perhaps a more reasonable guide for new admissions, but it's our understanding that that's what the department means. We will continue our discussions with them to clarify that moving forward.
If we have a resident in our quarantine area as required for the first 14 days and they are hospice, they cannot have visits?
That's what we would understand from the narrative. However, it doesn't explicitly state that in the grid, and it's unclear in the grid. And again, this is the same issue that we were just talking about. We will try to get clarity. We have tried to get clarity about this issue before, but the department has only come out and responded to the issue of visits for persons who are definitely COVID positive. So we're trying to get a better understanding of what their intention is here.
It mentions monitoring of visitation. What does that mean?
Well, one-to-one monitoring is not required. We assumed that it meant that just making sure that visitation overall is safe, that the precautions are being followed, etc. But the original plan for one-to-one visitation oversight that was in the first guidance is no longer required.
When prohibiting residents' visits who are in isolation or under observation for symptoms, a new admission doesn't technically have symptoms, so how does this truly apply?
When we looked at the language, to be honest with you, I tried very hard to make it not apply to anyone who didn't have symptoms. But it doesn't say to avoid visitation for persons who are suspected of having COVID or actually have symptoms of COVID. It says under observation for COVID. And so without further guidance, we can't 100% be sure what the department means, but it's our understanding that that was the intention when the statement was written originally from the epidemiologist.
Okay. Can indoor visits occur in a resident room, or do they have to be in a separate designated area?
They can be in a resident room if the resident room is private.
Okay. Does this order essentially do away of the level system for visitation, or is that still in effect?
So for right now, at least, it does away with it. Although we have to note that the administration may be using that level system for other things. The website is still up. There are still counties in level E, but essentially that is the major change. And that is that you don't have to look at the county risk level in order to determine visitation, what allowable visitation looks like.
Okay. This next question, I might just have you respond to them via email because it is a few paragraphs long.
Okay.
So we will just let you respond to that one. Can you clarify if children under 13 are allowed to visit? Also, CMS states if positivity rate is over 10%, must have a barrier. Does this apply to home for the aged?
Well, none of the CMS requirements apply to home for the aged, although their communal dining and activities have to align with their guidance on that piece. But other than that, no, none of the guidance that CMS puts out applies to homes for the aged. MDHHS is and Laura, obviously, drives the regulatory requirements for that facility. Can you repeat the first part of that question?
Can you clarify if children under 13 are allowed to visit? And then
the way, yes, when we read the guidance, it appears that children under 13 are allowed to visit. They're simply not required to be tested.
Okay. So it appears that all residential care facilities are encouraged to test staff and visitors, while skilled nursing facilities, HFAs, and AFCs are required to test staff and visitors. Does that mean that unlicensed assisted living are not required to test visitors?
Yes, my understanding that that's true. I believe that it's nursing homes. I'm not looking at the guidance in front of me, but it's nursing homes, HFAs, and AFCs who have 13 licensed units or more.
Do we need to test visitors every time they enter the building, or just the every 72 hours?
They must have a test within 72 hours that's negative.
I believe the previous rule stated that visitors only had to be tested when the county was in C and D on the Michigan Safe Start map. Does this mean that visitors will have to be tested even when the county is at a low B level?
Okay, well, first of all, there is a level called low. Then there's A, B, C, D, and E. I, again, don't have the testing guidance in front of me. I do believe that if you are in low, the testing requirements have not changed. And I do not remember the levels actually that don't require the testing, but I believe that those requirements are still in place. We can review them and look at them again, but the testing requirements have not changed from whatever that says. And forgive me, I don't have that in front of me, and it's been a while, so I don't remember it in detail.
Are HFAs still required to test staff on a weekly basis if the HFA is not in outbreak status?
Yes, the testing requirements have not changed.
What does LHD stand for?
I'm sorry, LHD, when I use it, stands for Local Health Department.
Volunteers are allowed even when there is an outbreak?
No. Blake, go back to the grid, please.
Okay.
Volunteers who have been trained in infection control measures and are supporting visitation, no.
Okay. This is from the Michigan.gov coronavirus website. Prohibit visits to residents who are in isolation or otherwise under observation for symptoms of COVID-19.
Yes.
This doesn't state 14 days. Can you provide a resource to share with families that they are not allowed to visit for at least 14 days after admission?
Persons who are COVID unknown are under observation for symptoms for 14 days. There is nothing that specifically says that they are not allowed visitation, except for that MDHH statement and an earlier April 2 memo from CMS for nursing homes that prohibited visitation whenever absolutely possible for anyone who's admitted for 14 days. So we're trying to clarify what the department's intention is at this point. We believe that this is burdensome and inappropriate. We have always believed that. We have never gotten the department to say it's not required. And that's what we've been trying to do for a long time, and we're still trying to do. They will say that anyone who is COVID positive is absolutely not allowed visitation, but they have not come out and said that that was their intention. So we're trying to get them to say that, but as we read that guidance, that's what it appears to us.
Okay. If you do your report, If you do report visitor POC testing, do you report it into Abbott and if positive to the health department?
Yes, you have to report it to the state through, I believe there's a website for that, and to the local health department.
Is it necessary to test the staff who cares for our bird cages and shredding staff if they do not enter resident care areas?
My understanding is that all staff have to be tested if they enter the facility in any way. Office staff, etc., they all have to be tested.
Can we prohibit visitors under 13 years old?
That's not clear. I would think that facilities should be able to make up their rules regarding safety protocols if you have a rationale that might be acceptable. But also remember that residents have a right to visitors. And so you would have to have a rationale for that. We're not aware. We really don't know whether or not Laura for nursing homes is going to really start looking at visitation. To our knowledge, to this date, they have not. Mostly, we think because they don't survey for the MDHHS rules. They only survey for the CMS rules. And since the state rules were more restrictive, we think that they've kind of stepped away from this. We don't know what's going to happen in the future. We really haven't had a chance to talk to Larry Horvath over there to see what his take on all of this is. And we will try to do that in the near future.
A surveyor told our staff that even though we require negative tests on admissions, the 14-day quarantine is required with full isolation status.
And that's my understanding. And I do know that earlier nursing homes did get cited for that. So we do know that that is applied to nursing facilities. It is not 100% clear in the surveyor guidance from Laura for nursing homes that visitation is precluded, but it is obvious that full transmission-based precautions are required, and visitation could be included in that based on how you want to interpret the isolation rules. So we still have to go back to, we believe that it was the intention of the department to prohibit those visits. We would like them to come out, actually get rid of the rule. However, at least be a little bit more clear about what they mean by that statement. But when we read it, someone under observation for symptoms includes people who are COVID unknown for 14 days after admission. We do want to note that CMS does not require that, however. And so you might want to think about that as you're looking at practices in your own facility for nursing homes, at least.
The guidance says we need to conduct point of entry testing when possible. Since we have POC tests, does this mean we have to test at every entry?
I would have to go back to the testing guidance. As I'm hearing the question, I believe you're asking every time a visitor enters the facility, do you have to test? My understanding, again, the testing guidance is not in front of me, that they have to be tested within 72 hours. Point of care testing, which will give you a report immediately, can be used for that, but if they've been tested within 72 hours, then testing is not, more testing is not required during that time frame.
AFC under 12 and AL exempt are encouraged to test. What do you recommend?
I would look at your own circumstances in your facility, what the community transmission rate's been, your staff issues. Are your staff moving and working in more than one place? I would look at how your residents are situated. Do you have the ability to isolate them if necessary? So it would really depend on what you think your relative risk is for your community. If there's high risk, then I would consider testing people because it is the staff mostly who bring in the infection to the residents, and testing staff on a routine basis and identifying outbreaks quickly that limits the risk of infection to other residents. So again, I think it's a good idea, but it depends on how risky things are. If all your residents have been vaccinated and most of your staff have been vaccinated, then you might consider not doing that.
How do we determine what transmission rate our county is in, low, moderate, or severe? Do the A to E levels correlate with this? CDC guidance uses the low to severe language for some guidance.
Can you say that again, please, Blake?
How do we determine what transmission rate our county is in, low, moderate, or severe? Do the A to E levels correlate with this? CDC guidance uses the low to severe language for some guidance.
So I don't remember where the delineation between all of that was, but it was extremely low using the MDHHS low through E categories. So I think that the state would consider anything probably C, D, E as high risk. The CMS considers their categories of green, yellow, red as low, medium, and high risk. So those are pretty much the definitions that I would use. I probably would stick with the CDC unless you're required to look at the state requirements for some reason.
So is that the only type of volunteer that is currently permitted, those supporting visitation?
That's my understanding, at least to date. We have found no other guidance that says that volunteers are allowed for any other reason.
You mentioned CMS requires a barrier for visitation when the positivity is over 10%. Can you elaborate on this?
I would have to pull out QSO 2039. I do believe that general visitation is not allowed for 10% or higher positivity rates, or it might actually be higher than 10%. 10% or lower, I think they allow general visitation. They still have ADL, end of life, compassionate care visit allowance beyond that. But general visitation, which pretty much is what we're talking about here, is not allowed in for nursing homes under CMS guidance QSO 20-39.
If you are testing visitors under 18, must you have parental consent?
I think you must. You do have to have consent for testing from just about everybody that you test. Going back to the testing guidance, which, to be honest with you, I've not reviewed lately. But you have to have consent. And so if they are not of age to give consent, I would think you would have to have a parent.
If they have a negative test, how are they considered COVID unknown?
They're COVID unknown because a negative test does not mean that you are free from the infection. It just means that you could have an infection, but you're not testing positive now. And that's why there's 14 days, because a negative test only really gives you the status for a point in time. It doesn't give you someone's status tomorrow or the next day. And in fact, I do know of a situation where a staff member tested negative one day, had symptoms the next, and was positive. So you can test negative and then still become ill from an exposure that you had before you tested negative. And that's the reason.
I do believe the state ombudsman office will be focusing on full access for visitors, despite if that is a Laura initiative or not. And since the ombudsmen are not entering buildings, they could opt to send a Laura rep instead.
That could be true. We do. The messages that we've heard from the Ombudsman Office is much more in terms of an advocate for the residents' rights to visitation. And I think that they have had concerns about the MDHHS guidance. And they tend to interpret everything fairly loosely, even though there's defined language that has restricted certain visitation over time. Yes, we do think that they are going to be pushing for more visitation as a resident right.
Okay, it looks like that was our last question for now, so we can move forward.
Okay, we just have a few more updates to finish out the day, and I'll go through them very quickly. The vaccines. As of 2/28, this is the MDHHS dashboard for vaccines. The goal in Michigan is to vaccinate persons who are 16 years of age and older. And at this point, the state reports that 17.7% of the population within that age range have currently been vaccinated. You can still see overall the impact of the age group priorities. Seniors are the largest group of persons vaccinated to date, either through healthcare providers and health departments or through the pharmacy partnership program. So at this point, almost 20% of the population who are adults have been vaccinated. CVS and Walgreens have completed all of their first clinics and the vast majority of their second clinics. The program will likely be completed soon in the next month or so. Just to let you know that Leading Age also has updated its frequently asked questions on vaccines, and we have again provided that link at the bottom of the page. Experts seemed quite delighted over the weekend with the approval of the Johnson & Johnson vaccine, and the president yesterday reported that there should be enough vaccines available in the country by May to vaccinate everyone. The FDA fact sheets on the newest vaccine are posted here, and there is a MDHHS webinar today that focuses on the new vaccine. The vaccine itself should be available soon. It requires only one dose and thankfully no altered cold storage. And we will be looking at more information about the vaccine as it comes out. There are always a number of resources on vaccines. Until visitation updates, it has been really the topic up for weeks. These toolkits from Leading Age and also from the CDC have been updated, and the links are here for you if you wish to review them. We want to let everyone know that there is a program sponsored by Leading Age on building systems, mechanical, electrical, and plumbing concerns, and how they can work to help mitigate transmission of infectious diseases. This program is going to be held on March 10th, and if you're interested, the link is at the bottom of the page. The Consumer Financial Protection Bureau has also put out some information, and along with a recorded webinar on COVID-related scams that target older adults. And they've also included some resources to help persons who are having financial difficulties related to the pandemic. Those resources and the recorded webinar are posted on the slide at the bottom. And this is our last piece, just a final note about NHSN reporting. This memo comes out every week now as a reminder for nursing homes to report Following a data problem several weeks ago, they did ask providers to check the accuracy of their data in NHSN the day following the data entry. It seems now that they're doing that on a weekly basis. So we're not sure that if they're always going to request that you check your data that you submitted the day prior, but at this point they are still asking for it. So, any final questions?
All right, thank you, Deanna. I did have one person say that they missed your answer to their question, so I'm just going to ask it again really quick. So is that the only type of volunteer that is currently permitted, those supporting visitation?
Yes. To our knowledge, we have found no guidance anywhere that allows any other volunteers. You would think perhaps that with the general relaxation of visitor requirements, that they would allow visitors for all sorts of assistance, and that's something that we will ask the department. But as the guidance is written, that's the only type of volunteer that is discussed as being allowed in the facility.
Okay, so with that, that actually will be our last question, or looks like it is our last question. So if you do think of anything after this webinar has concluded, as always, you can email Safe and Calm, Dalton, or Deanna at leadingagemi.org, and we will make sure to get that question answered for you. So at this time, we would like to thank both Deanna and Dalton, and we would like to thank I think this was actually a new record for us, 115 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. With that, I hope everyone has a great remainder of their Wednesday, and we will be back here for another Safe and Calm webinar next Wednesday, March 10th at 10 a.m. as always. So have a great rest of your day, and we will see you then. Thank you.
Take care, everyone.